Going back on the record, the time is 12:57 p.m.
Okay, doctor, right before the break, I was asking about the diagnostic test that Ms. Myers had when she was at Skyline. I'm going to pass to you Exhibit 20, and I've turned it to page 43, bait stamp 43 of that document. Let's just go down the list of the imaging diagnostic studies performed. She had an x-ray of her femur, correct?
Correct.
Okay, let's turn over to the next page. She had an x-ray of her pelvis, correct?
What page is that on?
The next page, 44.
Exam CT abdomen and pelvis. Okay.
Well, at the top here, x-ray, trauma,
Trauma
AP
pelvis. Okay.
Okay.
Correct.
And then she had a x-ray of her chest, correct?
Correct.
Then she had a CT of her chest, abdomen, pelvis, and looks like lumbar spine. Is that correct?
Correct.
Okay. Then turn over to page 48, doctor.
Okay.
She had at the very bottom of that, she had a CT of her face, correct?
Correct.
Next page. She had a CT of her cervical spine, correct?
Correct.
She had a CT of her head, correct?
Correct.
Then she had another CT of her head, correct?
Correct. You know what? I've just now discovered why you thought she had 3 CT scans. The one that's called trauma face was the same as the one that was called trauma head, because they were both done basically, they're both describing the same thing.
Okay, we'll get to that in a second. So.
Okay. That's the only way I can interpret that.
I didn't see any diagnostic study of her left arm, did you?
No.
If her arm was purple, would you expect them to do some type of study to determine why her arm was purple?
I can't account for other people's deficiencies. I don't know.
Okay. Well, in your practice, would you have conducted some diagnostic study to determine the cause of one of your patients' arm being purple?
I might have. I don't know. I wasn't there.
Well, you wanted, as a healthcare provider, if there's a clot that's occluding venous blood flow to that arm, you want to make that determination, correct?
A plain X-ray won't do anything for you. You have to do a venogram.
Right. But if you suspect that someone's arm is purple and it's being because there's no blood flow to it, your first thought's a clot, right?
Yeah, but a plain X-ray won't show a clot.
I know, but there's diagnostic tests to show clots, correct?
What?
There are diagnostic
Yes, there
tests
are.
available to determine whether or not a patient has a clot.
Correct.
Would a Doppler study show that?
May or may not.
Okay.
I'm not familiar with using Doppler with veins. That's possible. You may be right. I don't know.
Okay. But as a healthcare provider, and you got a limb that's purple, wouldn't your number one thing to be to find out why it's purple?
It depends on the context. And a lady that's got multiple life-threatening injuries, then I may not be worried about a purple arm.
Okay. But I bet on your differential, it's an occlusion of the veins or the blood flow to that arm.
That's correct, yes.
And if you don't have blood flow to an arm, you're going to lose that arm.
No, it's venous blood. And so you don't necessarily lose your arm when the veins clotted up. I know because I've had one in my own arm. And so when the veins clot up, there may be, it'll just resolve on its own.
Okay.
So it's not limb threatening or life threatening.
But I think you testified that dysphagia is characterized by pain, correct?
Correct.
Is it characterized by swelling?
Yes.
It's characterized by cyanosis?
Blue color, that's the cerulean.
All
Yeah.
right. Is it characterized by edema?
Say what?
Edema.
That's the swelling.
Right.
Yeah.
Right. So you got swelling, discoloration, and pain.
Pain, right.
Okay. Okay, I'm going to pass you what I've marked as Exhibit 25, which is the Skyline trauma flow sheet. And you see the triage narrative note at the very top of that document, Doctor?
Yes,
You see anything that indicates that her arm was discolored or swollen or anything about pain or anything about the arm?
no,
Okay. Then turn to page 66 of that document. And over on the right-hand column, you see where it lists diagnostics.
yes,
Okay. Do you see any diagnostic being performed of her left upper extremity?
do not.
Then if you turn to 67, on the left-hand column at the bottom box, where it discusses upper extremities,
Yes,
is checked within normal limits. It's WNL, correct?
where is that term used? Oh, you mean on the left-hand side or the right-hand side?
Right here, Doctor.
Oh, on the left-hand side.
Yes,
I thought
sir.
you said right.
I'm sorry.
That's correct.
Okay. Do you see any indication of anything abnormal or, that there's abnormal motor, wounds, deformity, amputation, pulse, and comments? Anything else indicated in there other than the upper extremity is within normal limits and she's got a pulse to her right and left upper extremity?
That's correct.
Nothing noted about anything being discolored or swelling or pain or anything, correct?
Correct.
Okay. And then you see the diagram of the body over here.
Yes,
Okay. You see there's a 3 to her left eye, correct?
yes.
3 at the chart at the bottom means hematoma.
I'm sorry, say that again. There's the 3 by her left eye, which says hematoma.
Yes.
Okay.
And then there's a P on that left shoulder, which means pain.
It doesn't say that.
Well, you see P.
I see P. I'm not sure what that stands for.
Well, look at the diagram at the bottom, the legend at the bottom. Right here.
Okay, laceration, abrasion, hematoma, bruise, amputation, deformity, gunshot wound, stab,
No,
burn,
sir.
open.
Right here.
Oh, it's up. It's not in the. It's out of place. Okay, pain. Yes.
Okay. Do you see anything that was marked on that left arm? Bruise, deformity, anything else?
No.
Okay. I'm going to hand you back to Exhibit 17, which is the emergency provider report. And she's given a physical exam, correct?
That's what it says.
Okay. And the hematoma to her left eye is noted, correct?
Let me see. Yes.
And her skin is noted as warm, dry, and intact, correct?
Yes.
No mention of anything being discolored or anything in relation to her left arm, correct?
Correct.
Passed you Exhibit 18, which is the trauma H&P. And on the subjective portion of that, where it says on exam, patient had ecchymosis and swelling to the left eye. Did I read that correctly?
What line down is that?
Right in the middle.
Okay, I got it.
You
Yes,
got it?
I see it.
Okay. Is there any mention in that paragraph about any ecchymosis, bruising, swelling, discoloration, pain to her left arm?
No, but there's mention on the next page if you don't want to talk about it.
No, we're going to get there.
Oh,
So-
good.
And you see where they even talk about her extremities, and it says she's hemodynamically stable in moving all extremities, correct?
Was this on page 73?
Yes, sir.
Identify the page step number, please.
73.
Oh, I see it, yes.
Well, wait a second, slow down, we're not in a race here. What exhibit is that, 18?
Yeah.
18.
And which page are you reading from right now?
1 of 16, also 0073.
And what was the second page that you were reading from?
We haven't gotten there yet.
Okay.
No notation of anything at issue with that left arm, correct?
Not on that page, not on page 1 of 16. no.
Okay. All right, let's go to the next page.
Okay.
Now they mention the left arm here, correct?
Well, they put an X on it, yes.
Okay. And you see what number 1 is underneath that, describing what that X is?
Yes.
What does it say?
It says blown IV site.
Okay, what does that mean?
That an IV came out.
Okay. No mention of any swelling, pain, or discoloration, or any deformity of that left arm.
You see what it says, blown IV site, that's all.
And then you see the diagram of the face right below that, and it's got an X over the left eye.
Yes.
Okay. If you turn to the next page, which is page 75, at the very top, what's it describe in relation to the
Ecchymosis
left
and
eye?
swelling.
Okay, and that's in relation to the left eye, correct?
Correct.
Okay. No mention of ecchymosis to the left arm in that diagram, correct?
No, but 1 also applies to the eye, so you have to assume that the left eye has a blown IV site.
No.
So that's ridiculous. You don't put IVs in the eyeball.
Doctor, you see under 1, underneath that, under the left arm, it says blown IV site. And actually, right before that, on the page 73, it says body, front, and back. And on the front and back diagram of the body, the only thing marked is the blown IV site to her left arm, correct?
Okay, so it continues from 1 to 2. Okay, I see.
It says body, front, and back.
Yes.
Then we have a diagram of the body, front and back. And the only thing marked on the body, front and back, is the blown IV site to her left arm, correct?
Correct.
Okay. And then underneath that, head, front and back, we have the eye, the left eye with an X on it, correct?
Correct.
And if you turn the page, that reference 1 says ecchymosis, swelling, correct?
I see.
Okay. There's no mention of a blown IV site in her eyeball, correct?
Well, it's hard to. It's confusing here because on page 2 it says blown IV site, and it's. I guess they're switching over to head. I think you're right.
Okay.
They're not talking about an IV in the eyeball.
No.
You're right.
People don't put IVs in eyeballs, correct?
Not that I know of.
All right, go to page 78 of that exhibit, please.
Okay.
And this is the portion of the physical exam, and they do an exam of her extremities, correct?
Yes.
And that reads dry, moves all, normal capillary refill, normal temperature, no clubbing, no cyanosis, no deformity, no edema, no swelling. Did I read that correctly?
Yes.
Okay. Turn to the next page.
Okay.
See where they examine her skin?
Say again.
The skin examination. Dry, intact, normal color, normal temperature. Did I read that correctly?
Yes.
Okay. Okay. Let's go back, stay on Exhibit 18 to page 88. And this is a diagnosis, assessment, and plan note by Alwyn Harriet.
Okay.
You see where Mr. and Mrs. Harriet says large ecchymosis left periorbital region.
Oh, down here.
Yes, sir.
Hmm?
Okay. Periorbital is I, correct?
Yes.
Okay. Any mention about any issue with her left arm in that note?
I don't see any. She puts extremities but leaves it blank, so I don't know what that means.
Mark as Exhibit 26, a neurosurgical consultation on January 28th of 2019. And if you could turn to page 16, this is...
Excuse me, would you double check that? I already had 26 down. Make sure you didn't do it twice.
Very likely. Did you indicate what was 26 by chance?
I thought it was a trauma flow sheet, and then you went to... So you were discussing about no clotted skin, how inherent... Okay, if you didn't, that's fine.
Yeah, I don't see a duplicate on 26.
All right, I'm sorry.
Thank you. No worries. All right, doctor, on page bait stamp 16 of Exhibit 26, you see where there's an examination of Ms. Myers' extremities?
Okay, on the one I've got, there's no 16. It ends in page 11.
No, sir. Bait stamp 16.
Oh, okay. Excuse me. Got it.
Extremities, warm, dry, normal capillary refill. Did I read that correctly?
Bates 16?
Yes, sir.
Oh, okay.
Yes, at the very top.
I see that.
Okay. No indication of any discoloration or abnormalities, correct?
Correct.
Skin, you see right underneath that, no gross abnormalities.
I'm sorry, what are you reading from here?
Right underneath extremities,
No gross skin, no gross
skin,
abnormalities.
no gross abnormalities.
Correct.
Is that correct?
Correct.
Okay. Okay, doctor, I think this is the one you wanted to talk about. Exhibit 19, second page. This is Bates 26. Where it says no obvious deformity.
Wait a minute, let's
Ecchymosis.
see who's writing this.
Let's refer to Bates stamp numbers, please.
Oh,
That's-
this is Harriet.
Dr.
No,
Reed.
it says DeWeese.
Doctor, when you look at a page at the bottom right-hand corner, you know this, there's Bates stamp numbers.
Uh-huh.
When you start reading from it, please give us a Bates stamp number.
I'm sorry, Bates 0025.
Thank you.
Correct. And I'm referring you to Bates 26, which is the second
Okay.
page of that
All right.
document. Left upper extremity, no obvious deformity, ecchymosis to the left forearm. moves extremities spontaneously, palpable distal pulses, cap refill less than 3 seconds. Did I read that correctly?
It says ecchymosis to left forearm. Yes.
Right.
Okay.
Okay.
Yes.
Have we before this seen any mention of ecchymosis to the left forearm before this note?
Is this the one I mentioned earlier? I can't keep them
It
straight.
is.
Is that
It is.
Exhibit 12?
19.
19.
But I mean, is it identical to Exhibit 12?
No.
Okay.
Okay, because I remember talking about ecchymosis to the left forearm before. I just didn't know where it was.
Right.
Okay, it does say that, yes.
Okay. All the other provider notes that we've gone through have not indicated any issues or deformities to that left arm other than a blown IV site. Is that correct?
Correct.
Okay. Show you what's already been marked as Exhibit 23. And you see on the subjective portion, this is the trauma critical care progress note from 1/28/19. On exam, patient had ecchymosis and swelling to left eye. Did I read that correctly?
Yes.
Do you see any indication of any abnormality noted to her left arm?
Correct.
There is or there's not?
There's not.
Okay. And actually, let's stay where we are. Extremities, you see where the physical exam is performed?
Yes.
It says dry, moves all, normal capillary refill, normal temperature, no clubbing, no cyanosis, no deformity, no edema, and no swelling. Did I read that correctly?
Correct.
And then skin, dry, intact, normal color, normal temperature. Is that correct?
Correct.
Okay. Okay, I'm going to mark as Exhibit 27, neurosurgery progress note, dated 1/29/2019. And I'm going to refer you to Bates page 1180, which is the second page of that document. Where there's an examination of her extremities, where it indicates that they were warm, dry, and normal capillary refill. Is that correct?
Yes.
Skin, no gross abnormalities. Is that correct?
Correct.
Back to Exhibit 24, which is a progress note dated 1/29/2019. And you see in the subjective portion, on exam, patient had ecchymosis and swelling to the left eye.
Yes.
You see any indication of any abnormalities noted to the left arm?
No.
You turn to page 1173 of that document, which is the next page. You see the examination of her extremities?
Yes.
And once again, it states dry, moves all, normal capillary refill, normal temperature, no clubbing, no cyanosis, no deformity, no edema, and no swelling, correct?
Correct.
And then underneath, where there's an examination of her skin, do you see that?
Yes.
Okay. Where it says dry, intact, normal color, normal temperature.
Correct.
refer you back to Exhibit 20, which is the discharge summary from Skyline. And I'll refer you to page 40, bait stamped of that document.
Correct.
Okay, and you see where they examine her head?
Yes,
It says bruising to face.
correct.
Okay. Then they examine her extremities, and it says dry, normal, temperature, no clubbing, no cyanosis, no deformity, no edema. Is that correct?
Correct.
And then once again, they examine her skin, and you see where it says dry, intact, normal color, normal temperature.
Correct.
Okay. So other than the ortho consult that described ecchymosis to the left forearm and the H&P, which described a blown IV site to her left arm, out of all the documents we reviewed, did you see any mention of any abnormality to that left upper extremity of Ms. Myers from
We're
Skyline?
just talking about what you've shown me here. That's correct.
Yeah.
Yes.
Well, you told Mr. Kelly you reviewed the entire chart page by page of Skyline, correct?
Yes.
Did you see anything that described that left arm as having any swelling, edema, abnormality, discoloration, or anything?
I believe I've seen it somewhere. It's not in any of the stuff you've shown me, but I'm sure I've seen that.
Can you point to the
No, I
page?
cannot.
Would that be important to your opinions?
Sure.
Okay, doctor, I'm going to mark as Exhibit 28 the resident summary from Hickory Hills when Ms. Myers returns on the 30th of January of 2019, and I'm going to refer you to this diagram here. And that diagram has diagrams of the body from the left side, the front, the back, and the right side, correct?
Correct.
On the diagram of the body from the left side, is there any bruising noted there?
Say the question again.
This diagram of the left side, do you see any indication of any bruising on her left side?
No.
Okay. Then they show bruising to her right arm, correct?
And her left arm. Correct.
No. Where does you say the left arm?
In the next picture.
That
Right
says,
here.
That says dry.
I'm sorry. I couldn't read that.
You see where that says dry?
Yes.
Okay.
I
It
do.
doesn't say bruising to the left arm, correct?
Well, here's the next one. The left arm says bruise right here.
That's on the elbow, correct?
It's the upper arm, halfway down the arm.
Okay.
So there is bruise on the left arm.
On the left elbow, correct?
And arm. It's halfway down the arm.
Okay. Then they got the bruise on the eye, correct?
Correct.
Then a bruise on the right arm, correct?
Correct.
Okay. Now, you and Mr. Kelly talked a lot about the bleed and the location of it.
Yes.
Now, isn't it true, typically with trauma, you see bleeding in the spaces outside of the brain, correct?
You can see them anywhere. In the
Would-
brain, in the ventricles, outside the brain, they can be anywhere.
Okay. Typically, you see it in the epidural space, correct?
You can see it in the epidural space. That's actually fairly uncommon.
Okay.
Epidural hematomas are pretty rare.
You typically see a traumatic brain bleed in the subarachnoid space, correct?
Yes, you can.
And you typically see it in the subdural space, correct?
Yes.
Okay. You don't typically see traumatic brain bleeds in the temporal lobe, correct?
That's incorrect. You can see it anywhere. And then the parenchymal hemorrhages are very common
Okay. Parenchymal means
in
bleeding,
the brain substance itself.
bleeding within the brain tissues itself, correct?
That's correct.
That's the temporal area, correct?
Any lobe can have it, yes.
Okay.
Temporal especially.
And parenchymal hemorrhages are typically caused by hypertension or high blood pressure, correct?
Some of them are, but by no means all of them. They can be from hypertension, from aneurysms, from trauma. They can be from anything.
It can also be from a tumor, correct?
Huh?
They can be from a tumor, correct?
Yes. Yes, they can.
They can be from a cavernous malformation, correct?
Yes, they can.
And they can be from an arteriovenous malformation, correct?
Correct, they can.
And you can see bleeding in the temporal lobe from a spontaneous brain bleed, like you said, from an aneurysm, for example, correct?
Yes, you can. Yes.
If you have an aneurysm rupture, are you going to see bleeding into the subarachnoid space?
You can see it. That's more common in the subarachnoid space when it's from an aneurysm, but they can bleed into the brain also.
Okay. Now, per the CT reports, the hemorrhage was in the left temporal lobe and then eventually spread into the subarachnoid and subdural spaces, correct?
Correct.
And there was no active or specific treatment for that type of hemorrhage, correct?
In a different context, a different kind of person, there might be. In an 88-year-old lady that's kind of frail, there's no surgical approach to that in the context of this lady. Any surgery is going to leave that person with a big deficit.
Now, as far as the surgeries, you talked about a surgery. That's something a neurosurgeon performs, not a neurologist, correct?
They make the decision, yes.
Right. The neurosurgeon, if you have a traumatic brain injury or any type of brain injury, the neurosurgeon is basically in charge of that patient,
He's the captain of the ship,
and
yes.
he or she calls the shots, right?
As far as treatment, now the neurologist can get involved in other types of treatment, such as treatment of seizures and so forth.
Now, as far as we talked about Eliquis briefly, you and Mr. Kelly did.
Yes,
It's a blood thinner, correct?
that's a poor word, but it's an anticoagulant. It doesn't make your blood thicker or thinner. It's just, but it's in the common vernacular, it's called a blood thinner. Yes.
Okay. And someone, if you're on a blood thinner, there's a risk of being over anticoagulated, correct?
Say that again.
If you're on a blood thinner, and there's a risk of a patient becoming over anticoagulate.
Correct.
And what does that mean in layman's terms?
You're more likely to bleed.
Okay. And as far as her coagulation or her anticoagulation, we just don't know if her blood was, if she was over anticoagulated or under anticoagulated or at a therapeutic dose.
That's correct.
Because there was tests to be done or could have been done that were not done in this case, correct?
And they were basically not available or useful. It takes several days to get the answer back. So.
Right. So they never test her blood to make sure whether or not she was over anticoagulated or under anticoagulated, correct?
That's correct.
So we just don't know.
We don't know.
And one of the first orders when she got to Skyline was to stop the Eliquis, correct?
Correct.
And there was no drug at that time that you're aware of that would have reversed the anticoagulation from the Eliquis, correct?
Correct.
Now, you gave some testimony about the death certificate, and did it have any impact or factor in your opinions in this matter?
It's incomplete, but I can't argue with it, no.
I mean, did it factor into your opinions or not?
No.
Okay. And in fact, I think you told me in your discovery deposition that they're basically pretty close to zero as being reliable to the cause of death. Do you remember giving me that testimony?
Yes, I was many death certificates are just, the doctor will just put down anything.
Okay.
And so this one's accurate. Yes. Like I say, it's incomplete, but it's accurate.
Well, let's make sure we got your prior testimony right. Go to page 100. Okay. 100, line 17. Question was, how reliable are death certificates as far as cause of death? Your answer was pretty close to zero. Did I read that right?
Yes.
Okay.
They can't be relied on. If they got it right, they got it right, but you can't rely on them.
And I think you said as a neurologist you do diagnose brain bleeds, correct?
Oh, yes.
Actually, the radiologist makes the official diagnosis, but in your capacity as a neurologist, you can also make that diagnosis, correct?
The radiologist interprets the scans. In context of all the other things, I can diagnose it, and the neurosurgeon can diagnose it, and the radiologist can diagnose it. The radiologist gets paid for entering a diagnosis and coding for it.
Now, doctor, would you agree with me that not every fall that results in head trauma results in a brain bleed?
Correct. Yes.
Would you also agree with me that if a patient is on a drug such as Eliquis, that if they have a head trauma, that they're more likely to bleed, have a brain bleed, than somebody that is not on a similar type medication?
Correct. I believe that. Yes.
And would you also agree with me that the bleeding would be more severe in a person that's on Eliquis than a person that's not on a similar type medication?
That makes, it sounds like that ought to apply. I don't know that anybody's ever studied that. It's intuitive that probably is right, but I don't know any proof of that.
Okay. And then people can have a spontaneous brain bleed without head trauma, correct?
Correct.
And people can have a spontaneous brain bleed without being on any type of medications, correct? We have exhibit, I think it's exhibit 8. Okay. I'm going to refer you back to exhibit 8, which is the head CT. Thank you. With the exam date of 1/27/2019. And you
Correct.
read from Mr. Kelly the impression of the radiologist
Correct.
from that study. But I want to focus back up on the findings, okay? Do you see where
Okay.
there's an acute perimetral
Parenchymal.
I always butcher that, hemorrhage versus a hemorrhagic contusion in the medial aspect of the left temporal lobe. You see that?
Yes.
What is a hemorrhagic contusion?
It means when you bump some tissue, it's basically a bruise. Contusion is basically a bruise.
Caused by trauma?
Yes, that's the usual context. I can't think of another reason to have a contusion.
Do you know what the radiologist meant when he said, or she said, acute parenchymal hemorrhage versus hemorrhagic contusion?
Right, she's saying she doesn't know whether it's an acute spontaneous parenchymal hemorrhage or a hemorrhagic contusion due to trauma. That's what she's basically saying.
Okay.
She doesn't know the cause.
And it's in the left temporal lobe, correct?
Yes,
And there's a small extension of the hemorrhage to the left tentorial insidia.
incisura.
Yeah. Where is that?
That's the membrane that covers the cerebellum. It's adjacent to the temporal lobe and posterior to it.
And you see where there was no other intracranial hemorrhage noted.
I disagree with that.
You disagree with the radiologist that conducted
Well,
the
it's
study and
incomplete.
interpreted-
She didn't mention the ventricular extension, so it's in the ventricle also. She didn't mention that.
What are you basing that on?
I saw it. I
Exhibit
didn't show
3?
it to you. I've mentioned it earlier.
You mean Exhibit 3 that's timed at 1:28 at 2:50 a.m.?
This is 128:19 at 2:56 a.m.
Correct.
Okay. Can I borrow that?
And doctor, before we move to that, Exhibit 8, the exam time.
Now,
Yes.
wait, Craig, we're not doing this. I object. You can't ask him something he's about to answer and then have him refer to something else. You'll confuse him.
Okay, that's fine.
So
Go ahead,
let's
doctor.
answer the question on the table first.
That's fair enough. Go ahead, doctor.
I'm going to say one more time. It's hard to know
Dr.
exactly
Rocher,
what date
Doctor,
these were done.
please hold that up for Mr. K. Thank you.
Okay. This is a lateral ventricle. It's a cave in the brain that contains spinal fluid, which is basically looks like tap water, and that's dark. This is her left lateral ventricle, and it's full of bright signal, which is acute blood. So she's got ventricular extension of her parenchymal hemorrhage. So not only is it in the temporal lobe all the way up to behind the eye, but it's also in the ventricle. And that makes it a lot more of a problem. So if you don't have ventricular extension, your outlook is a little better than if you do. So that's what I'm saying. She didn't mention that, but it's there. And it's easy to see.
All right. So it's actually a he, doctor, for clarification, but that's fine. But the Exhibit 8, the exam date is 1/27/2019 at 8:36
Okay.
p.m., correct?
Yes.
Okay. And then the timestamp on Exhibit 3 is 1/28/19 at 2:50 a.m., correct?
Okay.
Are you sure we're looking at the same CT image?
I don't know. No, I've told you before, these dates and times are all mixed up. I'm not sure that refers to this.
Okay.
She's had blood in the ventricle, as far as I know, ever since they started scanning her.
So the radiologist got it wrong on her or his report from that initial CT scan.
If the radiologist read this, after looking at this, they were incomplete. They didn't mention the intraventricular hemorrhage. It's not wrong, it's just incomplete.
Doctor, I'm going to pass to you Exhibit 29, which is the CT report of the head. Well, I got them out of order, so let me pass you this one first. Sorry about that. Yes. All right, doctor. Exhibit 30, I'm sorry, is the CT of the head that was done on the 28th of January. And compared to the CT of the head done on the 27th of January.
Correct.
Okay. Then it says, since the prior exam, there's been an extension of the hemorrhage into the left lateral ventricle. The amount of hemorrhage within the medial left temporal lobe, hippocampus, has increased. And there's an extension of the hemorrhage into the adjacent subdural space along the tentorium, as well as in the subarachnoid space adjacent to the left midbrain and pons. Doesn't this more lie and comport with Exhibit 3?
Yeah, he's talking about the lateral ventricle in this one. The one that is supposed to have been read on the 28th also talks about the lateral ventricle. And here's one here that I'm not sure when it was done. They don't mention the lateral ventricle. So it may be that it looks to me like, let me see. This is decompressed into the left lateral ventricle, which contains a moderate amount of hemorrhage, no hydrocephalus. Okay, so there's hemorrhage there, and I'm not sure exactly when this, it says here this was done on the 28th, so I don't know. I suspect this was done first, but I don't know that for sure.
Okay.
These numbers are mixed up.
And then you see Exhibit 29, which is on the bottom of your stack there. At
Yes.
the top, this was a CT of their head on 1/28/2019 at 1 p.m. And it was compared to the study done on 1/28 at 2:50 a.m.
Where are you reading from? Okay.
And then comparison. And on this one, there's noted to be very little change from the prior study. Is that correct?
Well, it says there's increased mild hemorrhage tracking along the left tentorium, so the subarachnoid and subdural blood is increased. I'll also mention that this scan was done on the 28th, and the comparison was to a scan done on the 28th. So then you have to assume that there were two scans on the 28th, I guess back to back, and that includes this one here. So the numbers, the dates and times get real mixed up here, and I couldn't figure it out. All I know is that she's got blood in the brain and in the lateral ventricle and outside the brain.
Okay, and based on these reports, there appear to be 3 CTs of her head, correct?
It appears to be. I've only seen 2 that I know of.
And the bulk of the blood was in her left temporal lobe, correct?
Well, you can do without a lot of temporal lobe. Blood in the ventricle is probably more important, but they're both bad.
The bulk of the blood is in the left temporal lobe. Would you agree with me?
Correct.
Okay. There's only a trace amount of blood noted in the subarachnoid space. Is that correct?
Correct.
And there's only a trace amount of blood noted in the subdural space, correct?
I don't know. This is only one scan. There may be other slices that show more, but there's a lot less in the subdural and subarachnoid space than there is in the brain.
Okay.
The brain has most of the blood.
And with head trauma, isn't there a certain pattern of bleeding that you would typically see in a person?
In some cases, sure, yes.
And that typical pattern is bleeding into what? The subarachnoid space?
Depends
and
on the cause.
Subdural?
It's caused, if it's an aneurysm, it's usually subarachnoid, but it can be intraparenchymal. If it's hypertensive, that's usually parenchymal. If it's trauma, it can be anywhere. So with trauma, you can have blood subdural, subarachnoid, epidural, intraparenchymal, intraventricular, anywhere.
So your testimony and your opinion is that the pattern of bleeding here with Miss Myers is typical for trauma.
That would be the top of my list, yeah. Now, it could be spontaneous. If you didn't have a history of trauma, you could say, well, I guess it could be spontaneous. But since you've got a history of trauma, you'd have to put trauma at the top of the list for causes of that blood, yes.
Could it be that Miss Myers had a spontaneous brain bleed, which was the primary event that resulted in her falling?
Anything's possible. It's much, much more likely than not, given the trauma, that it's caused by the trauma.
But that is a possibility.
Anything's possible.
Okay.
Could be from a meteorite, could be from a lot of things.
Have you ever heard of a cerebral amyloid angiopathy?
Yes,
That's a buildup of proteins in the arteries of the
amyloid,
brain.
yes. Mhm.
And that it can cause a spontaneous brain bleed, correct?
Correct.
And that's typically seen in people with dementia and Alzheimer's with the amyloid angiopathy, correct?
Old folks, yes. Can be.
And I think you told Mr. Kelly that Eliquis did factor in to your opinions to some extent, correct?
To a minor extent, yes.
And I think we've talked about this, is that you don't know how much of a factor it was because there was no testing done of her blood to determine the coagulation of it, correct?
Correct. But from my training and experience tells me it's more due to trauma than it is to Eliquis.
And you told me in your discovery deposition that it could be a bigger effect, or it could have Eliquis could have a bigger effect or a lesser effect on your opinions, one way or the other, but we just don't know because the test was
We
not
don't know.
done.
I'm just going by more likely than not.
Okay.
It's got a lesser effect than the trauma.
Now, the mass, the cecal mass that was found during some of the diagnostic testing at Skyline, there was no biopsy or test performed to determine whether or not it was benign or malignant, correct?
That's correct.
And you don't treat patients for cancer, correct?
Brain cancer, yes, but not for colon cancer. No.
Correct. You don't treat patients for colon cancer.
Correct.
And the radiologist basically indicated that it was malignant until proven otherwise, correct?
Correct.
I know during your discovery deposition you had some opinions in relation to sundowners. I didn't hear any opinions today, so I'm assuming you no longer hold any opinions in relation to sundowners in this matter.
Well, I have been asked, but you're right. I don't have any opinions different from what I said in my other deposition.
So that was a discovery deposition. Today is your evidentiary deposition
Oh.
that you're going to be using to present to Mr. K.
Okay.
Do you have any opinions as it relates to sundowners?
Yes.
In relation to Ms. Myers?
Sure. Yes, that's why we're here. Yeah.
And you agreed with me at your discovery deposition that those opinions were pure speculation, correct?
Whether she had sundowner or not, yes.
So any opinions you have in relation to Ms. Myers and sundowners is solely pure speculation.
Correct. Based on the information I have, I did not see anything in the record that used the word sundowners.
And nor did you see anything in the record that indicated that she was exhibiting sundowners on the 27th of January 2019, correct?
Correct.
And my understanding of sundowners, there is no biological basis for sundowning, correct?
There's no what?
Biological basis.
Well, there's some basis and there's some presumed basis. I mean, I think we talked about that before.
And there's no scientific studies to basically verify or validate that actually sundowning occurs in individuals with dementia, correct?
You know, I've never read that. I take it, you see it all the time in demented folks, so there's got to be a connection of some kind. I've never seen it studied scientifically, no.
And actually, people with dementia show erratic behaviors at all times of the day, correct?
They can, but they're more likely to do it after sundown.
Okay. But as far as Ms. Myers, once again, you have no basis for your opinion that she was experiencing sundowning at any time during her residency at Hickory Hills, correct?
Correct.
And you
Correct.
had no basis for any opinion that she was experiencing sundowning on the day of the fall on January the 27th, correct?
Correct.
Now, talked about pain that Ms. Myers may have been experiencing at Skyline. And I think when I took your discovery deposition, you'd indicated that you only saw 2 quantitative notations of pain at Skyline.
Say that again?
That you only saw 2 quantitative notations of pain at Skyline. Do you remember that?
If I said that, I've seen more than 2, but at the time I was deposed earlier, maybe I was referring to that.
Okay.
I think there's more, but I don't mind saying 2. It's okay.
And you testified that she was on pain medications from the time she was found to when she became unresponsive. Do you remember that testimony?
No.
All right, let's go to your deposition, doctor.
Okay.
Okay, 92, page 11.
Line 11?
Yeah, 92, line 11, sorry.
Okay.
All right. Question from me. I understand they continuously administered pain medication from the time of the incident until her death. Is that correct? Your answer was, I only saw 1 and maybe 2 indications of morphine. They also gave her Tylenol for pain. So somebody thought she was in pain until she became unresponsive, basically. So they were giving her pain medication from the time of the incident up until her death.
Objection. Objection.
No,
That's
they
misleading.
didn't
That's
start
not
the
what it
morphine
says.
for 24 hours or so, almost 24 hours. The morphine started on the afternoon of the 28th.
And just so the record is clear, let's go to ask you about the quantitative notations of pain. And what you mean by that is someone going in and rating her pain, either like a 4 or 5 or 10 or whatever it may be.
It's on a scale of 1 to 10, correct?
Right.
Or 0 to 10.
But there's different pain measuring scales depending on the patient, correct?
I don't understand your question.
There's different pain scales depending on the patient. You can't ask a nonverbal, unconscious patient what their pain is on a
That's
scale
correct.
of 0 to 10.
That's correct.
You have to use what's called the Flack Assessment.
I don't know.
You never heard of the Flack
I've
Assessment?
heard of it. I know. Those scales don't mean much to me. I know she was moaning and groaning, and you have to take nonverbal evidence that the patient seems to be in pain. I
Okay.
think that's what that's talking about.
And Flack, the acronym stands for face, legs, activity, cry, and consolability. Are you aware of that?
I've heard of it before.
Okay. And then there's also what's called a critical care pain observation tool. Have you ever heard of that?
Correct.
And the acronym for that is CPOT, right?
I think you're right. I've
Okay.
heard of that before too.
Did you see in the Skyline chart where they were using the CPOT scale and the Flack scale?
No, it's in there. I know. I don't pay attention to those pain scales very much.
Well,
I've
that's
never
how,
used them very much.
Well, isn't that how the caregivers of Miss Myers utilized the pain scales to make a determination as to how much pain she was experiencing?
That's correct.
Okay.
Yes.
All right, page 91. Line 11. And in those, you said there's indications that her pain is on a scale of 4 and 5 out of 10.
That was your statement.
That's my question.
Okay.
Your answer was that's the two notations, and you go down a couple of sentence. I only saw 2 quantitative or semi-quantitative of her indications of her pain level. One was 4 and one was 5. The rest of it is non-quantitative, and she's described as grimacing and moaning. Is that correct?
Okay.
But you're saying you've seen other quantitative notations of her pain?
It seems like it, but I'll go with 4. I'll go with 2.
All right, well, let's go through and examine the quantitative notes of pain. I'm going to show you the trauma flow sheet that was marked as Exhibit 25 previously. And this is at the time of admission on the 27th of January at approximately 2020. Is that correct?
2015. Correct.
And you see on page 67, which is the last page of that document, where her pain is described as a 4.
I remember. Oh yeah, pain over here. Right. Mm-hmm.
Is that a 4?
Yes.
Okay. Is that on a scale of 0 to 10?
Yes.
0 being no pain, 10 being the most god-awful pain, correct?
Yes.
Doctor, I'm going to mark as Exhibit 31 the medication discharge summary from Skyline. I'll direct your attention to the first page, which is Bates 105. And you see where her pain is rated as a 0 on the CPOT scale or score?
I see that.
Okay.
That was at a time when she was unresponsive.
What's the date on that?
Yep. It was.
Isn't that 127, the day of admission?
Well, up here it says 131.
I know, but we've got these dates.
Well, that's when she got sodium chloride.
Okay.
Up above that is where they have the 0. So it looks to me like the pain score things was entered on 131.19.
You know, if she's unresponsive, she's not feeling pain.
She's not manifesting any evidence of pain by 131, correct?
mark as Exhibit 2 the emergency patient record from Skyline. Just keep that in front of you, Doctor. We're going to go back to that. If you turn to Bates 68, which is the first page, from 127, 2019, do you see where her CPOT total score, pain score, was 4?
It's called pain intensity. Okay. Pain scale utilized, CPOT, pain intensity 4, correct.
Okay.
I also see where it says she's sighing and moaning, and tense and rigid.
Okay. Got a mark as Exhibit 33, clinical documentation record. For 1/28/2019 at 8 o'clock a.m. Do you see where her pain intensity is a 0?
You need to point that out to me.
I'll show you my highlighted copy.
I need a copy of that, please.
I only have these.
Well,
I see it.
Okay.
hang on before you go home, make sure.
And that was 128?
Yes, sir. If you, Mr. Kelly,
And
took
that
the
was at
document.
8 a.m.?
At the very top, 1/28/19, time 8 a.m.
Yes.
Okay, yes.
I'm sorry?
Probably need to change tape. Yep.
Yeah,
Change tape.
let's change tapes.
Going off the record, the time is 2:05 p.m. Going back on the record, the time is 2:06 p.m.
Doctor, back to the medication dosage summary. Discharge summary, my bad. Go to Bates 113.
Okay.
Okay, you see where it's timed at on 1/28/2019 at 16:46.
Yes.
Okay, and what is her pain intensity at that time?
Says 5.
Okay, then you see at the bottom at 17:40 it was reassessed.
I don't see. Oh, yeah, reassess 1746, correct.
Okay, and what was her pain intensity?
0.
Doctor, I'm going to mark as Exhibit 34, clinical documentation record from Skyline for January 29th at 7:45 a.m. And can you tell me what her pain intensity was on that document?
Two.
Okay. Doctor, I'm going to mark as Exhibit 35, Another clinical documentation record from Skyline. It's Bates number 920. That's dated 1/29/2019, timed at 15:12.
Yes,
You see where the comment says she does not arouse?
correct.
And pain status, you see the comment underneath that where it says does not arouse?
Yes. It's left blank.
Doctor. We'll mark as Exhibit 36. Another clinical documentation record for Ms. Myers from Skyline. That's dated 1/29/2019, timed at 16:10. Do you see that?
Yes,
And at the bottom of that, under pain status, what is her score?
NA.
No.
Well, stated observed pain level equals 0.
Okay.
So they said characteristics unable. So I will tell you that by that time of that day, she was either unresponsive or almost unresponsive.
But they do rate her level of pain on a scale of 0 to 10 as a 0, correct?
Well, they don't say what scale they use. All they do is stated or observed, so they don't say what they're talking about. But that's what it says. I agree with what they
Well, in
what you
parentheses,
said.
it has 0 to 10, correct?
Right.
And typically on a scale, pain scale, 0 means no pain, and 10 means the most god-awful pain ever, correct?
Yeah. I think this is the misuse of these pain scales. This is one reason I think they're unreliable. Go ahead.
Let's go back to the medication dosage summary, or discharge summary, and go to page 119 of that document. Okay. At 1/29/2019, at 1700, do you see what her pain scale is? Her pain intensity is?
4.
Okay. And then underneath that, at 2100, you see where her pain scale is reassessed.
Zero.
Mark as Exhibit 37, clinical documentation record of Ms. Myers from Skyline, Bates is 1029. And this is timed on January the 29th, 2019 at 8 o'clock p.m., correct?
Yes.
And what is her pain intensity?
No pain. 0.
No, I'm sorry, you're reading that wrong, Doctor. I want to make sure the record's correct. That's the goal. If you look below that, or on the other side, what is her pain intensity?
Okay, down here it's a pain. Okay, goal. Yes,
Yeah, the goal was no pain.
correct.
Not mislead you. You see pain intensity
Yeah,
on the right-hand column?
4.
4, okay.
That was after she had the 4 milligrams of morphine.
And then, I think we've talked about this, but back to this document. This is after the morphine, I think, where her pain is reassessed.
This one's at 1700. Okay, after the morphine, her CPOT total score was 4, pain intensity was 4. And I think that's why she got that big slug of morphine, 4 milligrams. And then by 8 o'clock, apparently, the pain was less.
And then by 9 o'clock, it was 0, correct?
I don't know, where's the 9 o'clock?
Craig, you just read. I'll concede it if that's what it is. He didn't.
2100, doctor?
2110, yes.
0.
0,
correct?
right.
Okay. All right. Thank you, doctor. I'm going to mark as Exhibit 38, a post form. And you're familiar with the post form?
What's it called?
Tennessee Physician Orders for Scope of Treatment. Have you ever seen or heard of a post form?
No.
Okay. This is basically where healthcare decisions are being made for certain areas. Do you see where Ms. Myers was made a DNR in place on comfort measures only
Yes,
on January 30th of 2019?
correct.
Okay. And comfort measures, according to this, is to relieve pain and suffering through the use of medication by any route, positioning, wound care, and other measures. Correct?
Relieve pain and suffering through the use of medication by any route, positioning, wound care, and other measures. Use of oxygen suction and manual treatment of airway obstruction as needed for comfort. Do not transfer to hospital for life-sustaining treatment. Transfer only if comfort needs cannot be met in current location. Treatment plan, maximize comfort through symptom management. I see that.
Okay. I'm going to hand you what's been previously marked as Exhibit 20.
Okay,
And this is the discharge summary from Skyline.
okay.
And I'm going to refer you to page 39, which is the second page. You see where her general appearance is described as sleeping comfortably, no acute distress?
Correct, on the 30th, correct.
Yes. Now, I'm going to pass you the progress notes from Hickory Hills, Exhibit 22, and refer you to the last page of that, which is Bates 262 from the Hickory Hills chart. And you see an assessment done when she returns on January 30th, 2019 by Nora White.
Yes,
And you see where it's indicated no signs and symptoms of pain or discomfort at this time.
correct.
Resident made comfortable and a comfort measures given. Did I read that correctly?
Yes,
Okay, then underneath that is another entry, this one by Martha Holmes, January 31st, 5:21 a.m. Patient is resting in bed with eyes closed, correct?
correct.
Patient has been given PRN ×3 for pain this shift. PRN is effective. No signs of discomfort are noted at present, correct?
Correct.
Okay. Then on February 1st, 2019 at 4:20 a.m., Ms. Holmes makes another entry, resting in bed with eyes closed. Morphine sulfate given at 12, 1, 2, and 4:15 for
Dyspnea,
dyspnea. That means shortness of breath, correct?
correct.
No signs of discomfort are noted at present, correct?
Correct.
Roger. I'm going to mark as Exhibit 39 the alive hospice records. Just ask you a few questions about these. If you could turn to date stamped 9 of those documents.
Okay.
Okay, this is the hospice certification, and you see midway down the page where it says her family has opted for hospice services as she is now a PPS 10% unresponsive with sporadic opening of eyes.
I see it.
Okay.
Yes.
Do you know what PPS is?
Haven't a clue.
I'll relate to it's the Palliative Performance Scale. Have you ever heard of that?
No.
Do you know what 10% means on that scale?
I suspect it's not very good, but
I'm object
I don't know.
speculation. Craig, he ain't been declared as an expert on hospice.
I'm just asking if you knew.
He doesn't.
I don't know.
Okay.
Sounds pretty low, though.
All right, I'll turn to page 2 of that.
2?
Yes. Bait stamp.
Okay. Okay.
See where it says patient is unresponsive but does open eyes periodically, especially when right arm is touched?
I see.
Go to page 73.
73?
Yes, sir.
Okay.
This is a skilled nursing visit note from the hospice provider dated January 30th, 2009. In the middle of that is a symptom assessment. Do you see where I am?
Got it. I
Her
see.
pain is rated as a what?
3.
Let's go to page 60.
6-0.
Yes, sir.
Okay.
This is a skilled nursing visit by the hospice nurse dated 1/31 of 2019. Turn to page 61. Do you see where her level of consciousness is difficult to arouse?
Yes.
Okay, turn to 62. Do you see her assessment of mental status, level of consciousness, non-responsive? Right in the middle, under psychosocial, cognitive status?
Okay, psychosocial cognitive status. Okay. I see it.
Unresponsive?
Yes.
Okay. Next page, 63.
Okay.
Under the emotional status, emotional behavioral coping mechanisms, and a review of systems, you see where that's all indicated that she's unresponsive or non-responsive?
Wait a minute. I see, yeah, non-responsive, affect flat, current mood, yada, yada, yada. Right. I see that.
You see on page 66, under her neurological status.
6-6.
Yes, sir. Her level of consciousness is unresponsive.
Correct.
Okay, go to 67. Under pain assessment, they use the Flack scale,
Where does it say that? Oh, I see.
and her
Right,
Flack
okay.
score is what?
Face, legs, activity, cry, consolability, I guess, cry and consolability, right?
All are scored at what?
0.
And her total Flack score is what?
0.
And the patient's pain severity is what?
None.
You go to page 68,
5'8"?
68.
Okay.
Do you see her conscience level?
Wait a minute.
Under palliative performance scale, conscious level 10%, drowsy or coma.
Oh, under palliative performance, okay.
Yes.
All right.
Did I read that correctly?
Palliative performance scale, I see, that's PPS, I
Yes.
guess. Okay.
And she's 10%, which means
10% what? There's ambulation activity, self-intake, conscious.
I know she's 10% drowsy or coma. Did I read that correctly under conscious
Correct,
level?
that's correct.
Go to page 53.
I'm sorry.
553.
5'3". Okay, we're going backwards. Okay. I got it.
You see a communication form dated 1/31/2019.
I see it.
Third row where it's indicated that she appears comfortable.
Appears comfortable, right.
Okay. Go to page 77.
Yes.
This is a medical social worker visit note from a live hospice dated January 31st of 2019. If you go to page 78, which is the next page, what is underneath her pain assessment?
Frequency of pain interfering, is that it? Okay, I see.
Yes. What does it say? Patient unresponsive?
Correct.
Okay. Next page, 79. Narrative notes. Social worker went to facility to meet patient and check on current status. When social worker arrived, patient was asleep in bed. She appeared to be resting comfortably and no pain or distress was observed. Did I read that correctly?
Yes.
Let's go to 81.
How many?
81.
Okay. You can probably tell by now I'm almost deaf. Go ahead.
This is a chaplain visit note from a live hospice dated 1/31 of 2019. If you turn to page 83 under the narrative notes,
Okay.
you see where it says patient appears comfortable, patient is unresponsive during the visit.
I see. Okay.
Let's go to page 4.
I see.
It's a note by the social worker that Ms. Myers appeared to be resting comfortably and no pain or distress was observed, correct?
Appeared to be resting comfortably and no pain or distress, right.
Okay. Then page 1.
Okay.
It's a communication form dated 1/31 of 2019 from a live hospice. Where
Yes.
it indicates that the patient appears comfortable,
Yes.
quote, just here and not interacting, end quote.
Yes.
Patient sleeping and appears comfortable, correct?
Yes.
The testimony you gave to Mr. Kelly about that she reacted to painful stimuli. You remember that testimony?
Yes.
And those are neurological tests, correct?
Well, anybody can do them, but that's what the neurologists and neurosurgeons do a lot.
No,
Yes.
I'm not saying that only that specialty does it. Those are neurological tests to determine what a patient's neurological functioning is, correct?
Okay. Yes.
And if you react to painful stimuli, that's like pinching a finger or a toe and seeing if there's any response, correct?
There's many of ways to
Right.
deliver painful stimuli. Those are a couple, right?
Right. But that's not an assessment of pain, correct? That's an assessment of neurological status.
Well, it's also an assessment of pain. If the patient withdraws to hand your pension, that's an assessment of pain. Yes.
That means they're responding to painful stimuli, not that they're in pain.
Oh, it's not like the spontaneous pain that the patient's experiencing. I see what you mean. You're right. It doesn't assess the patient's spontaneous pain. That's correct.
Right.
Before you got there.
It assesses if they are neurologically intact to respond to painful stimuli, correct?
Correct. Yes. She's capable of feeling pain. That's what it means.
Right. So it means that you do a neurological assessment to determine their neurological status, correct?
Correct.
And then you do a pain assessment to determine their level of pain, correct?
Yes.
Okay.
Yes.
All right, Doctor, that's all the questions I have. Thank you.
Bless you.
Take a deep breath. I need some exhibits, Ms. Court Reporter. I need exhibit number 9. Need exhibit number 18.
I probably have some of those over here, Clint.
18 and 19.
Here's 18.
All right, 19
That's 17.
and 28.
You said what, 19?
19 and 28.
Here's 19.
Cool.
18, 28.
All right.
And what was the other one? 9? What is 9?
I've got 9.
No,
9
what
is
is
the CT scan of the pelvis, which is a good place to start. Doctor, I'm going to go back to exhibit number 9. And we'll go down to the finding of number 2, where the radiologist found fracture of the left sacral ala, peripherally imposed on an old injury.
Correct.
Is there any reason that a radiologist would put this in there if they didn't see it?
Objection.
That you
I
can
can't
think
imagine any reason.
of. And have you seen?
That's the pelvis or sacrum, right?
Yes, sir.
Okay.
Look at it carefully.
Which one is it? Oh, yeah. Okay, got it.
CT scan of the pelvis, isn't it, doctor?
No, it looks to be, yes, it is. CT, right, correct.
And sometimes, have you seen situations where findings like this don't make it on the problem list for whatever reason?
Yes.
Objection.
In your opinion, that's what happened here, isn't it?
Yes.
Objection.
We spent a lot of time looking for sacral fractures, and there it is, isn't it?
Yes.
Objection.
By the radiologist who found it, correct?
I can't remember.
Objection.
Yes, yes.
And
I think in the total context of this thing, with a massive brain injury, I think a sacral alar fracture gets way down at the bottom of the list.
yeah,
It's causing a lot of pain, but it doesn't have to do with her survival.
the survival issue is the brain, isn't it?
Correct.
All right. Now, I'll make sure we spend a lot of time talking about ecchymosis, the left arm. Is there any reason you can think of why there would be a finding of ecchymosis on the left arm if it didn't exist?
Objection.
Can't imagine why somebody would say that.
Would somebody make that up from your experience?
Objection.
I doubt it.
Okay.
I don't believe that.
Page 2, Bates stamp 26, exhibit number 19, left lower extremity. Excuse me, left upper extremity. What does it say?
Ecchymosis to left forearm.
Why would that be in there if it wasn't true?
Objection.
Can't imagine why.
Yeah. Okay. Exhibit number 28. Let's get back to ecchymosis of the left arm.
Yes.
What was found by the person who did that assessment of her left arm on Exhibit 28? In that diagram.
Bruise right here.
Yes, sir. Where's the bruise, doctor?
Left arm.
Any reason somebody'd lie or make that up if it didn't exist?
Can't
Objection.
imagine why.
Okay. We spent 30 minutes going through hospice and hospital records about her pain after January 29 of 2019. In your professional opinion, did the hospice and hospital do a good job of putting Miss Myers out of her misery?
Yes.
Objection.
And finally, since Mr. Conley raised it, I want to ask you about sundowners. I want you to assume that in 3 separate places in the Hickory Hills chart for their care plan, they tell their workers that she has poor judgment issues under the psychosocial section. In your opinions, is that consistent with someone who has sundowners?
Objection.
I'm sure they go together. Yes, the answer is yes.
And did you know before today that Nurse Holmes, the one who participated in caring for Miss Myers, testified she had sundowners?
Objection.
No. Did not know that.
And just for the record, define what sundowners is for Mr. K, who probably already knows it anyway.
You almost always see it in old people, but anybody with brain trouble can manifest that you don't have to be old. And so when you're missing a lot of cognitive function, the frequent pattern is that during the day you seem to have good brain function, but as the evening comes on and the noises and sounds around you and the light stimulation and the activity stimulation diminishes, your brain starts to fill in information that's not in your real environment. And so you tend to see and hear things that aren't really there. You imagine what your brain's missing. And that's basically sundowning. And they call it sundowning because it usually happens after sundown. But like I say, anybody can have it, but you see it very, very frequently in old folks that are demented.
Finally, did any physician at Skyline Medical Center state in the medical records that this brain bleed was caused by anything other than trauma from a fall?
Objection.
No.
That's all I have. Thank you.
Now we're done.
That ends this deposition. The time is 2:37 p.m.